Okay. Hi, everyone. We'll start the session now. So we're going to look at common orthopedic emergencies. And we had Dr. Vikrant look through the presentation, and he was going to take the session as well. But unfortunately, he was caught up in an emergency, which is very common for residents. So I'll be taking it in his place. So let's see what all we're going to cover. So we're going to look at what all approaches you can take to common orthopedic emergencies. We're going to look at splints and tractions. And if there is time remaining, I'll cover some of the named fractures as well. In the pre-session questionnaire, I have asked you a few named fractures, but if we don't have enough time, then I won't be able to cover it, and I'll explain it on the group itself. And we'll have, as usual, case discussions. So the best mnemonic there is for common orthopedic emergencies, one CHOP. So you look at vascular compromise, open fractures, neurological deficits, compartment syndrome, hip dislocation, osteomyelitis, and pelvic fractures. So vascular compromise is again a very common thing that you see associated with fractures itself. You have to know how to assess these patients clinically, and there are specific signs that you look for. I will go over them as we go ahead. And again, neurological deficits. So one of the most common things that patients will come with is something called Cauda Equina syndrome. It's basically where you have compression of the nerve roots. Again, we'll go in more detail. Compartment syndrome is a buildup of pressure in the compartments of your limbs. Hip dislocation, self-explanatory, it's dislocation of the hip. And osteomyelitis, more commonly septic arthritis, and pelvic fractures. So let's start with fractures. So fractures are very common. You should know what are the different types of fractures. So in an X-ray, the basic thing as a clinician, you need to be able to identify if a fracture is seen and what type of fracture it is. Because depending on the type of fracture, your management will change. So if it's a transverse fracture, if it's a linear fracture, if it's oblique, non-displaced, oblique and displaced. So displaced basically means that the fracture parts have moved from its normal anatomy. Spiral fracture, where it's spiral across the bone, and green stick, where you have a like only a part of the bone is involved and it's not a complete fracture throughout. Comminuted, again, very commonly seen in road traffic accidents and crush injuries, where the bones are broken into tinier pieces. Okay, now there are certain principles that apply for fractures of any kind. If you understand these principles, irrespective of knowing what is the name of the fracture, which bones are involved, or the physics behind it, you will be able to figure out at least emergencies mein itna karna hai. So that involves fracture reduction. Reduction is restoring the anatomical alignment of a fracture or dislocation of the deformed limb. So dislocation has happened, deformity has happened, you want to realign it. So you can basically prevent vascular compromise. So around your bones, you have vessels and nerves. Every time you have a fracture, that fractured part might damage the vasculature and the nerve surrounding it. If you put it back in anatomical position, that is not going to happen. So what all it does is it tamponades the bleeding. So it's going to stop the bleeding because again, you've put it back into its normal position. It's going to reduce the traction on the surrounding soft tissue and reduce the swelling. It's going to reduce interaction on the transversing nerves. So it's going to reduce the risk of neuropraxia, that is damage to your nerves. And it will reduce the pressure on the blood vessels. So it will help you prevent any compromise to the blood supply. The main principle in any reduction, regardless of the method, is to correct the deforming forces. अगर ये bone है, ऊपर से pressure आया और नीचे गया है, तो तुम नीचे से ऊपर डालोगे. So it's a very logical thing in orthopedics, where if you apply the principles of physics, you'll be able to essentially reduce any fracture that you see. So the second part that you need to know, how to immobilize a fracture. So these are where your splints and casts are involved. Now, the two main things to know in this is, in the first 2 weeks, plasters are not circumferential. This is not always the case in children. Whereas, so what you do is, you have an area that is only covered by the overlying dressing to allow the fracture to swell. what you will see as a complication, if you put a circumferential plaster, no, and you don't allow the tissue to swell and heal, you will cause a compartment syndrome, which is very commonly seen. So a lot of the times, if you have worked with orthopedicians, seen orthopedic postings, they will tell the patient प्लास्टर लगाने के बाद कि अगर सूजन आ जाए या अगर पैर your limbs, your toes are not moving, come back immediately, because that means the patient is now starting to develop compartment syndrome, right? Okay. If there is any axial instability where the fracture is able to rotate along its long axis, such as a tib-fib metaphyseal fracture or a radial ulnar fracture, basically axial instability here along the axis of the bone is the instability. So you have to cross the joint above and below because you want to stabilize the joints. You want to stabilize the fracture between those two joints. So above knee fracture, above elbow plasters, all of these are very specifically for these kind of fractures, because it will prevent the fracture it will prevent the bone to rotate along the long axis. For most other fractures, suppose अगर मेरा यहाँ का fracture है, wrist fracture है, तो my plaster will go from below elbow and cover the entire wrist until here, the next corresponding joint. So my fingers will move. Right? So that is the logic. A lot of the times I get asked, how do you decide where to stop? So the next joint has to be involved, right? Okay. So what is the difference between a splint and a cast? A splint is non-circumferential. Splinting is a basic emergency management that you need to know. कहीं तुम PHC में काम कर रहे हो, रूरल एरियाज में काम कर रहे हो, बहुत commonly fractures आएंगे, and fractures can be identified even without an X-ray. Even on clinical suspicion, you can know if it's a fracture. What do you look for? You look for deformity, you look for swelling, you look for pain, you look for restriction of movement and decreased range of motion. So basically what you ask the patient to do is, if the fracture is on the wrist, you check for all the movements that the wrist can be, that you can normally do at the wrist. If the fracture is at the elbow, you do all the movements that you can do at the elbow normally. If there is any restriction in movement, if there is swelling, if there is deformity, then there is a likelihood of there being a fracture, and immediately you can splint it. So what are the indications? Acute and definitive treatment of select fractures, soft tissue injury. So if there is a sprain and you want to immobilize it, and while you're waiting for orthopedic intervention. So suppose you have asked the patient to immobilize in the field. कहीं तुम्हें patient मिला, तुम emergency में हो, or if it's in a rural setting where you can't get to an orthopedic center, you can splint it meanwhile so that it's not going to get further damaged by movements. So the advantage is, because it's not covering the entire surface, you can allow for swelling because you know कि swelling बढ़ने वाला है, right? So you will not have a risk of compartment syndrome. It's fast, it's easy to apply, it's very logical. And you can also use commercial splints, but most of the times you can splint with any flat surface and you can tie gauze to it. Now the disadvantage is, because there is not complete stabilization throughout the structure involved, there is a likelihood that because of the movement, you will aggravate the injury. So it's not completely immobilizing it, right? And it's not useful for unstable fractures where you know that they will get displaced again. So तुमने splint भी लगाया, but वो fracture इतना unstable है कि normal हाथ हिलाते हुए वापस displace हो गया. Whereas on the other hand, a cast is circumferential. It is a definitive management. It is simple, simple, complex, unstable, or potentially unstable fractures, because it provides such good immobilization, right? And again, it's more effective, but there is a risk of compartment syndrome. So here you can see you have two types of casts. You have a plaster of Paris cast and you have a fiberglass cast. Now, how do you apply a splint?
Have your partner support the extremity above and below the injured site. In this video, we are simulating a mid-forearm fracture. Ensure that you have circulation, motor ability, and sensation in the injured extremity.
Radial pulse. Squeeze my fingers. Touching your fingers?
Prepare your splint so it will properly fit the area you're going to be splinting. Gently apply it to the patient's skin while minimizing movement of the extremity. Using gauze or Coban, secure the splint to the patient's extremity. Remember to check for circulation, motor ability, and sensation after the intervention.
Have a radial pulse? Can you wiggle your fingers? Can you feel me touching your fingers?
Yes.
Did you guys understand what he mentioned before? So he said, make sure even before you apply a splint, this is the most important part.
Have your partner support the extremity above and below the injured site. In this video, we are simulating a mid-forearm fracture. Ensure that you have circulation, motor ability, and sensation in the injured extremity.
So 3 things that he mentioned that you need to remember before applying any splint or traction or any cast is make sure there is sensation, there is motor ability, and there is vasculature present. These 3 things you have to identify first, because agar isme compromise hai, there is no time to wait. You take them immediately to the hospital, and if you apply a splint, you might actually make it worse because you don't know what is compromising that vasculature or that nerve supply. Okay? So make sure of all these things. That is why whenever a suspected fracture patient comes, it's not a patient that you can, just write painkillers for and send away. You have to make sure of these things because the patient might potentially lose their limb. Okay? Everyone understood till now what we have discussed? Yes, no. You want me to repeat something? Okay. Now, how do you apply a POP cast?
Today, I'm applying a below-knee cast made of Benecast POP Gold. This is suitable for all ankle and foot indications. However, in addition to emergency treatment, such as the application of back slaps POP, is often used for indications that require a very close moulding, such as displaced fractures, talipes, or total contact casting for the treatment of diabetic foot ulcers. The products required include 1 piece of 7.5 centimeter Benecast stockinette, 1 roll of 15 centimeter Benecast undercast padding, 4 15 centimeter rolls POP Gold. Position the limb appropriate to the indication and maintain this throughout the application. On this occasion, it is in a neutral position with the ankle at 90 degrees. Apply the stockinette from the toes to the tibial tuberosity. Ensure it is smooth throughout with no wrinkles. Using the 15 centimeter undercast padding, start to wrap at the base of the toes with a double covering. This will provide sufficient padding to be folded for a soft edge to the cast. Keeping the roll close to the limb, continue wrapping, covering 50% of the previous turn, paying particular attention to the heel, working towards the tibial tuberosity. Complete this procedure with a double turn at the proximal aspect and tear off the roll. This provides the foundation of a well-fitting cast. Today, the product of choice is the Benecast POP Gold. I will use 4 rolls of 15 centimeters. If desired, apply examination gloves to prevent your hands from becoming dry. Remove the roll from the wrapping and immerse the roll into cool water until the bubbles disperse. Cooler water will provide a slower set time, whilst room temperature water will decrease the set time. Give a moderate squeeze to remove the excess water. Start a bandage at the knee around the distal aspect of the tibial tuberosity, covering 50% of the previous turn. Work the bandage down the leg. At the toes, continue with the bandage back up to the limb, applying extra layers over the foot and ankle. Now take the second bandage and repeat as with the first. This will ensure even coverage throughout. Smooth the cast to laminate the layers and ensure the cast is strong and durable. If desired, turn back the ends of the stockinette, of which this should be no longer than 2 centimeters. Ensure there are no rough edges and that all the toes are exposed, and the knee can flex to a minimum of 90 degrees. Depending on the indication, synthetic casting material, such as Benecast Advanced or Benecast Select, can be used at this stage to complete the cast and produce a perfectly moulded, very durable combi cast. However, if continuing with POP, take the third roll and repeat as you did with rolls 1 and 2. However, start slightly lower to maintain the soft edge and capture the end of the stockinette. Mould the cast to ensure it is smooth and has good lamination. Now continue this process with the final roll, replicating the application technique as before, ensuring you have even coverage throughout. Now change places with the person supporting the limb and mould the cast well, using one hand to mould and one to provide support, alternating to prevent indentations. Ensure the cast is smooth with good lamination throughout. Continue to mould the cast until it feels dry to touch and slightly brittle. It will sound a little hollow when tapped. Check the cast to ensure it is not causing constriction of the knee or at the toes. I would now suggest you rest the limb on a pillow. This type of cast can take between 24 and 48 hours to dry fully. Written and verbal cast care instructions should be provided to all patients wearing a cast.
Sign up to the Benecare Academy to download a PDF step-by-step application guideline of this tutorial and be the first to watch when we launch new videos. benecaremedical.com/academy.
Okay, so this is essentially an ad for the company, but did you guys understand how they put the plaster? Ignore the advertisements. But it's a really nice video where they've explained the 3 layers of plaster that they've put and how you start from a lower level so that you have a soft edge. Okay, good. So, depending on the type of fracture you have and the area of injury, you can use specific type of splints and casts. This is a little too high level for you, but I've just kept the table in if you're interested. So, agar hand fracture ka hai, thumb splint ka hota hai, it's a type of splint. and a cast. Then if it's a forearm or wrist, so you can have a short arm or a long arm cast. If it's an elbow or forearm, you can have double sugar tongue or a long arm cast. Okay. Now moving on to the actual like big emergencies, there is something called as pelvic fractures. But to understand a pelvic fracture, you need to first understand the anatomy of the pelvis. So your pelvis is made up of a couple of bones. You have the sacrum, the what you call your you have the sacrum, you have the coccyx, which is your posterior part of the hip. You have the ilium and you have the pubis bone. So वहाँ पे pubic symphysis बनता है, which we consider as a marker. So that's made from the two pubis bones. And below you have the ischium. Now this is all essentially a part of the hip bone and the anatomical structure. You have the femur, which is in your thigh, and then you have the acetabulum. So you see the head of the femur that goes and attaches into the socket of the hip bone. Right? It's a ball and socket type of joint. So the pelvic ring is formed by two innominate bones and the sacrum and the supporting ligaments. The true pelvis contains the rectum, bladder, and uterus in females, as well as the iliac vessels and the lumbosacral nerve roots. So why we focus on pelvic fractures so much is because whoever is drawn on the screen, can you please delete that? Yeah, thank you. And the others as well, the rest of it also. Okay. Okay. So a reason why pelvic fractures are so important to know is because your blood vessel in your hip is very extensive. So there are a lot of vessels in this area that can get damaged in case of a fracture. So you have a lot of internal bleeding that happens, which obviously is life-threatening. So the patient will become unstable very quickly. So how do you differentiate between a stable and an unstable pelvic fracture? So the stable fracture will not involve the pelvic ring. So this you see the upper part, the sacrum border, the ilium border, pubis. This is your pelvic ring. So it doesn't involve the pelvic ring, and there is not a lot of displacement. Whereas an unstable fracture will involve the pelvic ring and has significant displacement. This is the Young Burgess classification for pelvic fractures. The reason why I've put this is, it's okay if you don't know the classification, but the logic that they're using, if this is your hip, right? Your hip is like this. If you're putting lateral compression on it, these are the kind of fractures you will get. If you're putting anterior posterior compression on it, so those are the type of fractures you'll get. Which part is being affected depends on the type of force that's coming. Okay. How will you manage these fractures? You have to first assess the patient. It is very important to know if the patient is hemodynamically stable or not. If the patient is in shock, you have to put, the first thing you have to do is put a pelvic binding, which you see here on the right side. So you can do it simply with those bandages, or you have the binders that are specifically made for the pelvis, depending on the stability of the patient. Then you will do an X-ray, you will do a chest X-ray, you will do a pelvic X-ray, and you will do a FAST. Can anyone tell me what is FAST? We've gone over this in the very first session of this series. FAST, E-FAST. Does anyone remember? Nobody? Okay. So FAST is focused assessment, right? We've done it you do an ultrasound to look for free fluid in the abdomen. So there are 5 different areas that you check. So you do a FAST, you do the USG to look for free fluid. Then pelvic fracture without hemoperitoneum. Basically, there's no fluid in your peritoneum or hemothorax. There's no fluid in your thoracic cavity. You stabilize and you do a body CT. Now, there are not a lot of fractures that require a CT. So this is very important. In case of pelvic fracture, you do a CT to visualize the fractures clearly. Focus assessment with sonography and trauma. Great. And if there is active bleeding, you will do arterioembolization or hemodynamic. If if the patient is hemodynamically unstable. If you do a pelvic fracture and it's not stabilized, right? The patient is not getting stabilized, then you immediately take them into the operating theater for hemostasis using surgery or embolization. So you have to understand that these patients at your level, you have to know how to assess the patient and that you have to stabilize the pelvis. Okay. Moving on, you have something called hip dislocation. Again, very common. These are of two types. You can have posterior dislocation where the head of the femur has come out and moved behind, right? Piche chala gaya because of anterior force. Whereas in anterior dislocation, where there has been force coming from behind and it has moved forward. So what do you do in a hip dislocation? So these are very common in car accidents where the patient is inside the car. So if there is a forward force that comes in, it pushes the head of the femur behind. So the leg, what happens is it gets internally rotated, adducted, and shortened. This is a very classical finding you will get in patients who are brought in with dislocations. Then what you can do is something called an Ali's maneuver, where you flex to 70 degrees and you apply traction in line with the femur to bring it back into the socket. So anterior dislocations are obviously less common. So you will give traction in line with the deformity and you apply a lateral force to bring it back. Okay. This video, I remember watching it even during my final year exams because orthopedics is better visualized than read through a textbook. Okay. Did you guys understand this? Hip dislocation and fracture, pelvis fractures? Okay. Moving on. Now, compartment syndrome that I've mentioned multiple times before. So compartment syndrome is basically when you have pressure building up inside the compartments of your limbs. So it can be your leg, your thigh, foot, forearm, and buttock. So what are the signs that you look for? The 5 P's of limb ischemia: pain, paresthesia, pallor, that is pale skin, paralysis, that is weakness with movement, and pulselessness. You'll not be able to feel the distal pulse. You have to especially monitor for these symptoms in patients wearing casts. Now, the treatment for compartment syndrome is very logical. Jahan bhi pressure ban gaya hai, tumhe pressure relieve karna hai, so you take an incision and you allow the blood and the build-up pressure to release. What are the indications for doing it? Now, this is a clinical diagnosis, so it's not something you can tell on an X-ray. There are methods to measure the pressure, but it's very less likely that the machines will be available to you. So if you have clinical suspicion, you can perform a fasciotomy. If you have the machines available, the compartment pressure should be more than 30 millimeters, and the perfusion pressure should be less than 30. Now, regardless of the specific compartment involved, all compartments in the in the affected extremity should have the fasciotomy performed. Now, if suppose only your forearm has multiple compartments, it has an anterior compartment and a posterior compartment. If there is only build-up pressure here, you have to perform a fasciotomy in the other compartment as well. Okay, moving on. Cauda Equina syndrome. So it's basically neurological deficit. So the spinal nerve roots that are coming out are getting compressed in the thecal sac of the lumbar spine due to an acute lumbar disc herniation. Early diagnosis for these cases is essential, and they come with very specific clinical signs and symptoms. So what is the history? The patient will usually have a history of lifting heavy objects with the spine in flexed position. And you can also ask them if they have any medications that are taking. So if they're taking any anticoagulants, especially elderly people, they will come with patients who have history of MI, who are on heparin or warfarin, things like that. So unme hematoma formation ho jata hai. Any injury that happens, because there is no clotting, you're trying to prevent a clot formation for MI patients or stroke patients. So anytime they get an injury, they'll get blood bleeding, it will not clot, and instead later on it will form a hematoma. That can cause compression of the nerves. Or if they are IV drug abusers, right? Because there is a risk of infection, abscess formation, and again it will compress the nerve roots. Symptoms are back pain. It is most commonly presenting symptoms. Now, the thing that you need to be able to identify is, in any back pain patient, take a history. Is the pain radiating down to the limbs? Is it radiating down the thigh, down the foot? If it is only back pain, that is very common in elderly people, or if you've been sitting for a long time, that is different from a pain of Cauda equina. If it is radiating, that should send out red flags in your head. Unilateral or second or bilateral leg pain and saddle anesthesia. Then the other symptom, because your nerves are involved, your nerves in that region supply your bladder. So your sensation to the urinary bladder will cause incontinence. So as soon as the bladder fills, the patient will not be able to control the voiding, and it will cause overflow. So you can have unilateral or bilateral sensory changes in the legs, and you can have motor weakness. The rarer symptoms might be sexual dysfunction and bowel dysfunction. How do you manage these cases? Now, because as you saw in the first image, यहाँ से nerve root निकल रहा है, यहाँ पे compression है. So anything that's compressing it, you see this posterior part of the spine, that's called the lamina. So if I want to relieve the pressure, same logic, I will cut this part off. I will perform a laminectomy, this marked part. So if I cut and remove this part, it will automatically relieve the pressure and make it easier for the nerve roots to go out. Your job at your level is to be able to identify these things, right? अगर तुम्हें suspicion लग रहा है कि if the pain is radiating, if the history is very classical, you have to get an orthopedic to take a look at the patient and manage it accordingly. Okay, another very common condition, septic arthritis. Basically, septic arthritis, sepsis, you must have heard of before. So in this, there is inflammation of the joint secondary to an infection that can be bacterial, fungal, mycobacterial, or viral. It is usually monoarticular. However, polyarticular septic arthritis may occur involving small joints. But in general, septic arthritis, think of people coming with very red knees, swelling है एक knee में, बहुत like suddenly आया है, but history है infection का. Now, depending on the organism, you can figure out the cause, and depending on the cause, you can figure out the organism. So in healthy adults, the most common cause, the most common organism is Staph aureus. So if the joint was previously damaged, अगर पहले कोई implant डाला है joint में या prosthetic joint है, this is likely to get infected. So that is done by Staph aureus. Now, Neisseria gonorrhoeae is seen in sexually active young adults. So from an STI, it becomes septic arthritis. Whereas you'll get mycobacteria, fungal infections in immunocompromised patients. Patients with HIV, patients with severe diabetes, uncontrolled diabetes, they are more likely to have infections by mycobacteria and fungal species. Right? Okay. Now, how do you diagnose these cases? You do something called a blood culture and a joint aspiration. So you do a blood culture, you take blood from 3 sides, 2 to 3 sets of blood culture. You have to rule out infective endocarditis, and you have to check there any implants or prosthetics and device that have been put into the body. You aspirate the synovial fluid and you do 3 things. You do a fluid analysis, you do a fluid culture, and you do molecular tests. What you're trying to look for are definitive signs of infections in those fluids. So once you do that, what will you see? A normal synovial fluid will have a WBC count of less than 150. It will be colorless and the viscosity will be high. As the changes occur, so if it is septic, the WBC count will obviously be high. Any infection, any inflammation, your WBCs are going there to fight it. So the count increases. There is formation of pus. So it will be yellow-orange and the viscosity will become thinner. Now, when do you do surgical drainage? If you have septic arthritis of the hip, shoulder, or a prosthetic joint. Prosthetic joints, again, I'm reiterating, very common to get infected, especially if the patient is not maintaining hygiene. If you're not getting enough aspirate, right? That means you're not able to aspirate any fluid and you're not able to completely diagnose it based on the lab investigations. And you are not able to get the patient better despite the fluid aspiration. So you can aspirate the fluid. उसके बाद भी अगर patient better नहीं हो रहा है antibiotics पे डालने के बाद भी, so you will have to go for surgical drainage. Antibiotics, you have to give empirical antibiotics, obviously, for a period of 4 weeks. And how do you decide the antibiotic? Again, anytime you prescribe antibiotics, always know or have an idea of which organism is involved and why we're giving that antibiotic. So less than 12 months of age, if they have Staphylococcus, Group B Streptococcus, and gram-negative bacilli, we'll give first-degree cephalosporins. Then if it is 6 months to 5 years, we give second or third degree cephalosporins. 5 to 12 years, first and Staph aureus, first generation cephalosporin. 12 to 18 years, gonorrhea involvement, you give oxycillin or cephalosporin. So even when you have something as common as sore throat, understand if you have a suspicion of a bacterial infection, is there an indication for an antibiotic? If you're not suspecting a bacterial infection, there is no need to prescribe an antibiotic despite what the patient tell you. Patient आके बोलेगा antibiotic लिख दो, जल्दी ठीक होना है. It doesn't matter. Especially for moving on, if I talk about something as common as say viral fever or a cough and things like that, every patient will come and ask you कि antibiotics दे दो. जरूरत नहीं है. It's going to give, you're going to get better in 7 days, irrespective of whether I give you antibiotics or not. So you have to understand that it's important to counsel patients, but it is also important to know where antibiotics are essential. Because a lot of the times we indiscriminately prescribe antibiotics and they don't complete the course. उसके वजह से resistance हो जाता है. The organism will become resistant to the antibiotic that you've given, and those antibiotics will not work on the organism anymore. This is very commonly seen in TB, where you have single drug resistant TB, multi-drug resistant TB, XDR TB, and the situation is actually getting worse, where patients are now not even responding to the last line of antibiotics that we have. Okay, so again, I kept the session short. If you want, I will explain the named fractures on the group itself, because it makes more sense for me to explain it visually and mark out all the x-rays for you. One of you had also asked me a question about how to differentiate between the Smith and Gillespie fractures. So like that, I'll send you an explanation of all the different named fractures. Okay, case 1, 62-year-old man came with worsening knee pain. Symptoms began 10 days ago, unable to bear weight. Known case of DM and hypertension, not compliant with medication. The right knee is erythematous, that means it's red, it's swollen, and it's tender. There is decreased range of motion. You did lab investigation, you get an elevated ESR and CRP. You did a joint aspiration, that's arthrocentesis. And you get a WBC count of 65,000 and gram-positive organisms. What is your diagnosis? What do you think the diagnosis is? Anyone? Septic arthritis, right? Why is it septic arthritis? The most definitive thing is तुमने joint aspirate किया, उसमें तुम्हें gram positive organism मिल रहे, and you're getting an elevated WBC count. Case 2. A 33-year-old construction worker came to casualty with complaints of severe back pain radiating to the lower limbs since 4 hours. Also complaints of tingling and numbness in the bilateral lower limbs. On examination, vitally stable, and there is no bleeding wound. What can you suspect? What can it be? Lower back pain radiating to the legs. Cauda equina, yeah. So not all lower back pain is cauda equina, but lower back pain radiating to the limbs should send out red flags. Good. Especially with a history of trauma. Okay, case 3. A 40-year-old male brought by friends to casualty, history of fall on outstretched hands while playing football. Patient complains that pain or deformity of the forearm. There is tenderness over the left wrist, swelling, and deformity of the left arm. What is your diagnosis? How would you like to manage it? Colles fracture, right? So what is a Colles fracture? A Colles fracture is a fracture of the distal end of the radius and dorsal displacement of the anterior portion. ठीक है, ये जो आगे वाला broken part होता है, ये towards the sky, towards dorsal side displaced हो जाता है. You can see the fracture, it moves upwards. And that is why you get a dinner fork deformity. The opposite of this, you get a Smith's fracture. Yeah. So in case the dorsal part moves downwards, posterior displacement hota hai, you get a Smith's fracture. Agar upar ja raha hai, to Colles fracture. Now, how would you like to manage this patient? Okay. So I'll simplify it for you. If you're in a rural setting, you don't have access to orthopedics, the bare minimum you can do is put a splint. You have a clinical suspicion of a fracture, you have an X-ray. Put a splint, send the patient for further management. If you are at an orthopedic center, you can do the X-ray, confirm the fracture, and then put a cast. And before putting a splint or a cast, always make sure that the nerve supply, the vascular supply, and the sensation and movement is maintained. Case 4. A 20-year-old girl is brought to casualty with a history of fracture of the distal radius 2 weeks ago. A cast has been applied, but now she has swelling of the forearm, severe pain, tingling and numbness, and pallor of the fingers. On examinations, you don't feel any pulsations in the distal fingers. How will you proceed? Compartment syndrome, fasciotomy. Exactly. So for any fracture you get, uske distal pulses examine karne hain. You do it as a habit and you will do it forever. Range of motion check karo, swelling, tenderness, distal pulses. Case 5. 60-year-old male brought by relatives to the casualty with a history of fall in the bathroom at home, complaints of inability to walk, pain in the hip and groin. On examination, blood pressure is 90/50, pulse is 120, X-ray finding. If you're not that sure, it shows you a fracture. Here, you can see it. What further investigations would you like to do? Yes. So you can do a CT. Another thing you would like to do is a fast. You want to do a USG, you want to do a fast to check for internal bleeding. You're looking for free fluid in the peritoneum and the thoracic cavity. You're also going to do a CT to clearly visualize the fracture and accordingly proceed for management. That's it. These are the references. There are a lot of great videos for orthopedics available that I'll share with you guys. Orthopedics is very difficult to understand if you don't have visual cues available to you and if you're only reading from textbooks. So if you guys are stuck at any point, you don't understand what a fracture is, how it's functioning, what is the logic of why it's breaking the way it is, you can always feel free to ask me. I'll try to find a video and that should help you get some clarity over how things work. Thank you so much for joining. I hope you enjoyed today's session. And I will see you in a few days for our last 2 sessions.